right, so it's time for part 2 of causes of ST elevation, or part 2. So let's get through that. We've already done part 1. There's another video up for that if you haven't seen it already. So causes of ST elevation, just real quickly, this was mentioned in the part 1 video, but the ST segment is the early part of ventricular repolarization. It's seen right after the J point, which is the junction between the QRS complex and the ST segment. Now, in most situations, the ST segment should be essentially isoelectric, but as we mentioned in the part 1 video, there is a normal variant or normal situations in which we have a slight bit of ST elevation that's completely normal in men, and especially in the precordial leads, and we also see it a little bit less so in women, but it's still out there and it can be a normal variant. So how do we know if the ST segment is isoelectric or not? Well, we can compare it to a couple different other isoelectric segments. One being the TP segment, that's the segment between the T wave and the P wave, but if the patient's tachycardic, that wave is very short or sometimes not present at all. So then we can look to the end of the PR segment to see if it is isoelectric, if the ST segment is isoelectric at the same point that the PR segment is. So we've already talked about all these conditions in red, except for left bundle branch block and left ventricular hypertrophy, which we'll get to in this slideshow, and then we'll talk about the ones in green in this slideshow. So ST elevation, how do we know what the cause of that ST elevation is? Well, there are a few different questions that we can ask ourselves to try to help pinpoint the cause of it. So number one, what is the ST segment morphology and shape? This is very important, as you've already learned from the previous lecture, that typically the benign causes of ST segment elevation are going to have a concave morphology or a saddleback morphology, whereas a convex morphology or that tombstone or humping morphology is much more concerning. And so the other questions we can ask ourselves is, what is the location of the ST elevation? Is it in several leads, or is it just in those precordial leads that we would expect some normal ST elevation? We can also ask ourselves if there's any other EKG features that may point to another diagnosis. So we'll get into left ventricular hypertrophy. So if we see that on the EKG, we know that the ST elevation is likely the result of that. How much elevation is present is another good question to ask ourselves in trying to figure out what the cause of the ST elevation is. Are the changes dynamic? Do they change from one EKG to the next? Do they change from 10 minutes ago or 6 months ago? Are there any reciprocal changes? That's a big one for diagnosing an MI. And what is the patient's clinical appearance? Are they having pleuritic chest pain consistent with pericarditis? Or are they having palpitations, or what else is going on with them that we can look at in their history that might help us to have some clues as to the cause of the ST elevation? All right, well, let's go through some additional causes of ST elevation that we didn't get to in the part 1. So left bundle branch block and left ventricular hypertrophy. You probably remember this from some previous lectures in class where we talked about, well, there's the dog. Hang on a second. All right, I think we got the dog calmed down for the moment. So appropriate discordance. This is what we see in left bundle branch block and left ventricular hypertrophy. In other words, when we have those deep S waves, we see ST elevation and upright T waves in those leads. And that will be a cause of ST elevation. Don't do it, Kalmar. My dog is trying to do it again. All right. So 1 minute. All right, the dog is outside now. That should be the end of that. So left bundle branch block. There are 2 bundle branches that come off of the bundle of his that help to bring the wave of depolarization down and through the ventricles. If that left bundle is cut off, we have to rely completely on the right bundle branch to depolarize the entire ventricle. And that's why with the wave of depolarization having to come from the right and go all the way across to the left side of the ventricle, that's why the QRS complex is wider, and that's why we have wide QRS complexes with bundle branch blocks. So again, with a left bundle branch block, what we typically see is just a QS wave in V1 and a totally positive R wave that sometimes has a little notch in it in V6. And again, appropriate discordance. This is when we expect to see some ST elevation with a deep S wave and the ST depression with a tall R wave. So this too, left bundle branch block, is a cause for ST elevation. Here's the appropriate discordance slide. So left bundle branch block, this is an example of it here on this 12-lead EKG, where we see a wide QRS complex, a totally positive R wave there in V6, and a negative QS wave in V1, a little bit of ST elevation there in the V1 and V2, and that is appropriate discordance. Left ventricular hypertrophy is yet another cause of ST elevation. It has very similar repolarization abnormalities as left bundle branch block. In other words, where we have deep S waves, we're going to have ST elevation. Another situation in which we have appropriate discordance. Get used to hearing that term. I know we've discussed it some in class in the past, but you'll hear it a lot through this lecture. So left ventricular hypertrophy having that appropriate discordance, so where there's deep S waves, we have ST elevation. And as you may remember, left ventricular hypertrophy has like a gazillion different ways to make that diagnosis. The most common criteria are the Sokolow-Lyon criteria, where you add the S wave in V1 plus the tallest R wave in either V5 or V6, and that would equal more than 35 millimeters. Another really sensitive criteria, really specific criteria, but not very sensitive, is measuring the height of the R wave in AVL. If it's greater than 11 millimeters, it's most likely from left ventricular hypertrophy. Other things we look for are left axis deviation and a strain pattern where we get some ST depression and T wave inversion in those leads that have tall R waves. Here's a couple of examples of left ventricular hypertrophy and left bundle branch block. And you can see that they have appropriate discordance that's causing the ST elevation. Here's a single example of left ventricular hypertrophy. You can see that the voltage is very, very high here in V1 and V2 as well as V5 and V6. In fact, the QRS complexes are running on top of each other. So you can look at this, you don't even have to count the number of small blocks. You know there's going to be more than 35 here, and so this patient either has left ventricular hypertrophy or a very thin person, athletic person, sometimes we can see this. But the main point here, left ventricular hypertrophy is going to cause ST elevation, and it's another cause for it. Here's a chart that compares left bundle branch block with left ventricular hypertrophy, and you can pause if you want to take a look at that. A ventricular pacemaker will also cause ST elevation. We've talked about paced rhythms in the past, and this is very similar to a left bundle branch block. If you remember that oftentimes when a patient has a ventricular pacemaker, the wire is placed into the right ventricle. And so that wave of depolarization is having to go all the way from the right ventricle all the way across to the left ventricle, very much just like a left bundle branch block. So the pattern we get on the EKG is very similar. And so we have those deep S waves, we're going to have the ST elevation and upright T waves. Again, appropriate discordance. So a ventricular paced rhythm is going to be another cause for ST elevation. And here's an example of an AV paced rhythm. We can tell it's a pacemaker that is pacing the atria and the ventricles because there are two pacing spikes, one before the P wave and one before the QRS complex. Here's a rhythm strip again of a paced rhythm. You can see the wide QRS complex, the deep S wave with the ST elevation and appropriate discordance. Okay, now on to a new topic that you've not heard of before. This is called Brugada syndrome. Now, Brugada syndrome is a sodium channelopathy. In other words, this is a genetic disorder that can cause sudden death. These are people who had no idea that there was anything wrong with them, very possibly, until they drop down dead and die. Now, what we've seen is this is a fairly new concept for a fairly new diagnosis that we're aware of. It was first described in 1992 by the Brugada brothers, and now that we have some awareness of it, we're detecting it more often. In fact, in 2005, it was reported that it was the second leading cause of death in males under the age of 40. So this is something that you very well may see in your practice down the road. So it's very important that you're aware of it because there's still a lot of providers who aren't aware of Brugada syndrome. So there is an EKG abnormality called the Brugada sign. This is kind of the telltale feature that you're going to want to look for. This particular wave or this particular morphology is going to be seen in V1 and V2. And what it is ST elevation and a partial right bundle branch block with a coved morphology. So look at it closely. If you remember when we talked about right bundle branch block, we talked about an RS-R prime. And you can see that this has the RS with the R prime kind of being part of that elevated ST segment. So ST elevation and partial right bundle branch block in V1 and 2 with a coved ST morphology. What we see is that these ST changes are completely transient and can be unmasked when certain things happen. So if the patient comes in with a fever and you happen to get an EKG, you may detect it, whereas you couldn't have before. If they're having some myocardial ischemia or they've taken certain medications such as calcium channel blockers, beta blockers, nitrates, sodium channel blockers, and alcohol, now you may be able to detect the Brugada sign. Hypokalemia and hypothermia are a couple of other things that can make the Brugada sign show up on the EKG. So the diagnosis of Brugada syndrome is upon two things. You have to have the characteristic EKG finding called the Brugada sign, the one that you see here on this page, and some clinical criteria. And so that means that they've had some symptoms like this. That means that they've either had a documented history of ventricular fibrillation or polymorphic VTAC, a family member that they know of that died under the age of 45, somebody else in the family that they already know has this type of morphology on an EKG, or a syncopal episode. So they come to the emergency room or come to see you after a syncopal episode, you do the EKG, and you see this Brugada sign, you can make the diagnosis of Brugada syndrome. Again, Brugada syndrome is another cause for ST elevation. Get used to looking at that pattern. It's something you want to be able to identify on your patients. You don't want to miss Brugada syndrome. Ventricular aneurysm, this is another cause for ST elevation. And typically a ventricular aneurysm will come after a patient's had a really big MI. The myocardial wall becomes weak, and when the pressures increase inside of the heart's chambers, it pushes that wall out and you get this ventricular aneurysm. And what it will cause is persistent ST elevation that sticks around maybe weeks after the MI has taken care of itself and has been they've been to the cath lab and the angioplasty is done, but the ST segment elevation is still there. What we would do in these patients is we'd look at an echocardiogram to see if in fact that's what's going on, and if they needed it, maybe they would be sent to surgery. So ventricular aneurysm, something to keep in mind with persistent ST elevation. Raised intracranial pressure, well, yeah, it can cause ST elevation. Probably not the way that we're going to make the diagnosis for raised intracranial pressure. These folks more than likely, if they've got EKG changes from this, are going to have some pretty significant mental status changes. They're going to catch your attention well before you're thinking about doing an EKG and looking at that. But with raised intracranial pressure, you can see these giant T-wave inversions, and I'll show you those right now. Look down there where it says EKG changes with stroke. These humongously deep T-wave inversions is what you can see along with some ST elevation. You'll also see QT prolongation with raised intracranial pressure and some bradycardia, which is part of the Cushing reflex. So raised intracranial pressure, something you can keep in your differential, but like I said, these patients are going to come in with some mental status change and something else in the history. Takotsubo, baby. Okay, this is a really neat and interesting condition. It's what we call stress cardiomyopathy. And so these patients have absolutely no coronary artery disease, but they come in with ST elevation and symptoms that look just like an MI. And typically what we see is it's in postmenopausal women, and it's an emotional trigger that caused this thing to happen. Had a patient with Takotsubo a year or two ago. In fact, she was a pharmacist that worked in our hospital. She came in with chest pain, and she ended up arresting. We did CPR on her, taken to the cath lab, and completely normal coronary arteries. But what she had ended up being diagnosed with was Takotsubo. And we see that their LV function is reduced, and that they've got a wall motion abnormality. In other words, when they look at the myocardium under an echocardiogram or a right heart catheterization, that they can see that one of the ventricle walls is not moving or contracting like it should. They will even come back with positive biomarkers and maybe an elevated BNP, but the key here is that they have absolutely no coronary artery disease on the cath. These patients go to the cath lab, they're treated in just the exact same way as we would if we thought it was a STEMI. So other less common causes of ST elevation that we'll get to in other lectures will be pulmonary embolism and acute cor pulmonale, acute aortic dissections, hyperkalemia, sodium channel blocking drugs, J waves from hypothermia and hypercalcemia. Again, probably not the way you're going to diagnose hypothermia. A thermometer may be the best way. You can also see ST elevation after electrocardioversion or defibrillation. So if we just did CPR, we defibrillated the patient, pull out the 12 lead, it's very possible you'll see some ST elevation just from us having done the defibrillation. Other things would be cardiac tumor, myocarditis, pancreatitis, and gallbladder disease. So yeah, pancreatitis and gallbladder disease. So lots of different causes for ST elevation. And hopefully during this lecture, you begin to narrow down the possibilities by looking at the ST morphology, other things that are going on the EKG, how much is there, how much elevation is there, what leads do you see it in, are there reciprocal changes, what does your patient look like? These are all things to consider. The other things to consider is no matter how good these rules are, nothing is 100%. Almost 20% of so-called STEMI cases that get sent to the cath lab, once they get there, they've got normal coronary arteries. So we overcall STEMIs all the time. I guess better to overcall than undercall it, right? So, hey, just be on the safe side, call the cardiologist, let them get a good look at the 12 lead, let it be in their hands, okay? And always obtain an old EKG if possible. If you can get a hold of an EKG from several months or a few years ago and compare it to what you've got today, that may be a really great clue as to what's going on, what's causing the ST elevation. And just remember that people with real heart disease and really have an ischemia and infarction, that 15% of them may come in with chest pain that is positional and pleuritic. So don't blame it on pericarditis and don't blame it on benign early repolarization unless you're certain of those diagnoses. And hey, if there's any doubt, don't forget, get a serial EKG. Repeat it in 10 minutes. Check to see if there's been any significant change. EKGs are cheap and painless. Don't hesitate to get another if you think it will help to clarify the diagnosis. And in case you were wondering, background sound effects were provided by these two. Well, that's it for now. We'll see you next time.